colleagues, in partnership with Nephrology Dialysis Transplantation, NDT, the official journal of the European Renal Association, Marcus at Home welcomes Dr. Naseema Gangat and Dr. Ayalew Tefferi in Rochester, Minnesota, with whom we would like to discuss erythrocytosis in patients on SGLT-2 inhibitor treatment, which is a hitherto underappreciated side effect of our wonder drug in cardio-nephrology. Based upon their own original data, Dr. Gangat and Dr. Tefferi have recently published an editorial on this topic in NDT, which is Andreas Kronbichler's and my NDT's pick of the month. So dear Naseema, dear Ayalew, thanks so much for accepting our invitation. It's a pleasure to have you tonight.
Thank you.
Dr. Naseema Gangat and Dr. Ayalew Tefferi are both professors of medicine and hematologists at the Department of Medicine of the Mayo Clinic Rochester. Their major focus of clinical and academic work are myelodysplastic syndromes, myeloproliferative neoplasms, and acute leukemia, where they have written more than 200 joint publications in less than 10 years, virtually all in leading medical and hematological journals. So again, it's a pleasure to have you. And we would invite you to start our discussion by briefly giving us an idea why this topic is of importance.
Thank you so much. It's a pleasure to be here this morning with Dr. Tefferi as well from the Mayo Clinic. And we're going to introduce the topic on SGLT-associated erythrocytosis, on how we stumbled across this through our hematology practice. So just to refresh everybody's memory, SGLT2 inhibitors are also known as gliflozins. There are several agents that are approved by the US FDA plus the European Medicine Agency, and those agents are listed. Here, I highlighted 3 medicines which are most commonly prescribed in the United States: empagliflozin, dapagliflozin, and canagliflozin, and that's where most of our experience is based off. The indications for treatment are increasing day by day. The approval started with type 2 diabetes mellitus, and it has expanded to heart failure and chronic kidney disease. And hence, we're here on the nephrology forum discussing SGLT2 associated erythrocytosis. So with the increasing prescriptions for these medicines, we stumbled across this entity in our hematology referrals, where patients were being referred to our clinics for evaluation of erythrocytosis. And typically, the definition goes by hemoglobin and hematocrit that meets the criteria for diagnosis of polycythemia vera, which is a myeloproliferative neoplasm. So hemoglobin hematocrit values above 16.5 and 49 in males, and 16 and 48 in female patients. So those were the referrals we saw. And the first, we described this entity in 2021, which was about 2 years ago. We had seen about 30 patients. These were patients whose peak hemoglobins were 17.9. They ranged up to 19.8, as you can see. Peak hematocrit was 52.9 and as high as 60.1. And the percentage change in hematocrit was about 7.4%, which is substantial. And interestingly, there's 6 patients who had discontinued treatment, and their erythrocytosis resolved after discontinuation of therapy. So this phenomenon was already noted in the clinical trials with the empagliflozin and several SGLT2 inhibitors. So we were able to see this happening to the patients that were referred to our erythrocytosis clinic. So we expanded our observations this year. We have now evaluated 100 cases, and this was published earlier this year. And once again, we noticed the similar increase in hemoglobin and hematocrit, hemoglobin of about 2.5 grams per deciliter and hematocrit of 7.5. But I do want to highlight that some of the changes in hematocrit were quite profound, as high as 21.1%. And the 16 patients who discontinued treatment, there was resolution of erythrocytosis. So in the most recent paper, we tried to dig into what kind of treatments these patients received, what was the outlook for these patients, because typically when hemoglobin and hematocrit levels are increased, there is concern for risk for thrombosis, hyperviscosity, and risk for thrombosis. So here we were able to learn that the management practices were quite heterogeneous for these patients. Phlebotomy or blood donation was recommended in about 29, which is a little less than third patients. Antiplatelet therapy was prescribed for majority of these patients who were already on it, because as you see, the median age is 62, majority are males with some cardiovascular risk factors. But we wanted to see how many of these patients actually got thromboses while on treatment. And we identified over the course of a median follow-up of 2 years that 10 patients had experienced thromboses while on SGLT2 inhibitor, which is kind of counterintuitive because the reason why the indications are expanding is because of the cardiovascular benefits as well as the renal benefits. There were 7 arterial events and 3 venous events, and we did analyze the associations between hemoglobin levels, hematocrit levels, and treatments, and did not find any particular association of the peak hemoglobin or hematocrit with the occurrence of thrombosis. And in fact, phlebotomy, patients who were on phlebotomy had a higher incidence of thrombosis. And in a retrospective series, it was a little bit difficult to make any suggestions, but it makes us concerned that phlebotomy may not be the right answer in these patients. So while we were studying the SGLT2 associated erythrocytosis, which is JAK2 unmutated, we came across 9 cases where the use of SGLT2 inhibitor actually led to unmasking of an underlying myeloproliferative neoplasm. So these were patients who did not have a diagnosis of MPN at the time of starting treatment. Their baseline hemoglobin and hematocrit levels was within the normal range, did not meet criteria for polycythemia vera, and they had experienced, out of these 9 patients, 3 of them experienced thrombosis, and 4 incidents of thromboses were identified. And I have on this slide here the time frames at which these events were identified and when MPN was diagnosed. And as you can see, patient 1 presented with an MI, and the hemoglobin and hematocrit levels were substantially elevated, 19 and 60%. And once the MPN was diagnosed, treatment with the SGLT2 inhibitor was continued, but the patient after a few months had a stroke when the hematocrit levels were above 45, which is kind of our treatment thresholds for polycythemia vera, for phlebotomy to keep strict hematocrit control. This patient was already on all the correct measures, was on phlebotomy, aspirin, and hydroxyurea, suggesting that it is critical for us to identify cases where NPM may be unmasked because of the use of an SGLT2 inhibitor. So based on these findings, we do recommend that patients, before they start the SGLT2 inhibitors, we have a careful review of their blood counts. If their hemoglobin and hematocrit levels are borderline, to consider JAK2 testing for all these patients to make sure there's no underlying MPN which may manifest itself. This is not the case in the majority of patients, but given the information I shared with you in the earlier slide, it can be detrimental if it is missed because the management considerably differs. So I'm going to stop here, and I'm happy to take questions and we can continue with our discussion.
Well, thank you very much. That was amazing. As Gunnar already mentioned, I think most of us nephrologists have not been aware of that phenomenon, and it's quite striking to read your recent letters. So let me start with one question, actually. So how often did the pivotal trials using empagliflozin, dapagliflozin report on erythrocytosis?
So that's a difficult question because these trials did not report on the incidence of erythrocytosis by like the absolute values of hemoglobin hematocrit. They went by the percentage increase. So if you look at the empagliflozin study, there was a 5.5% increase in the hematocrit levels and a little less than 1 gram per deciliter increase in hemoglobin. It is very difficult to compare the trial data because the focus of those trials were more cardiovascular outcomes, diabetes outcomes, renal outcomes, and not necessarily hematological parameters.
Then, of course, we are also interested in why is that happening? Is it mainly because of the diuretic effects of SGLT2 inhibition, or are there other substantial hints in pathophysiology how SGLT2 inhibitors are actually increasing hemoglobin and hematocrit?
I think that's a very good question. I mean, that is the spice that everybody is trying to test. Nephrologists, cardiologists, we, because of the erythrocytosis. And as you know, everybody reads the same Bible, meaning we all read what's out there, and everybody has an idea as to what might be happening. And so basically, we feel that your organ, which is the kidney, is critical here because that's where the natriuresis, the glycosuria happens, and that changes the dynamics within the tubules and what we don't know, there are so many sensing mechanisms in there that are in closely aligned with the renal vessels and changing the tones of both the afferent and efferent, and also the distribution of energy, whether it is through the medulla, the cortex, and what have you. And we all read all that. So therefore, the potential arguments that are given out there can be organized into two approaches. One is it's all the kidney. Whatever is changing in the kidney somehow is producing a hypoxic environment, whether you want to say shunting of energy to the distal tubules, causing a hypoxic state where the interstitial fibroblasts are vulnerable and therefore produce erythropoietin. That's the renal approach. The other approach is that SGL-2 is not necessarily a private property of the kidneys, and that it is also elsewhere, especially other organs, and they feel that these drugs can actually have a similar effect on this linked transporter that actually might affect the production of some regulators, broad regulators, such as hypoxia-inducible factors, SIRT1, and those perhaps might be equally responsible for the induction of erythropoietin production. At the end of the day, whether it is via SIRT1, whether it is a hypoxic state in the renal environment, it all ends up in the production of erythropoietin. So now consider yourself like you're not in the United States, but if you went to Colorado, you'll be at high altitude. So you'll be in a hypoxic state. The erythropoietin goes up, the hemoglobin goes up. All right. Now consider yourself. If you stayed there, the erythropoietin will come down to where it was. So once your hemoglobin goes up with the feedback, and just imagine that you are permanently living in Colorado. And that might be what these drugs are doing, is they're permanently producing, as long as they're in there, in the body, a hypoxic state that then helps in the production of erythropoietin, either via the hypoxia-inducible factors or the SIRT1. And you and I both know that these products, whether it is HIF or SIRT1, it's not only erythropoietin, that is, they help as a transcription factor. It's not, they're not just promoting the production of erythropoietin. There are so many other drugs, the things that are produced. And I think that is the common linkage in their overall activity, whether it is to protect the kidneys, whether it's to protect the heart, or whether to cause erythrocytosis. I think these are all linked within this master regulators. And I think the problem that most of the studies do not realize is you don't expect the erythropoietin to be elevated when you check it once the hemoglobin is up. It normalizes. So that kind of gives you the perception that it has nothing to do with erythropoietin. No, it has everything to do with erythropoietin. And I think that's where we're at. And which is very interesting is because we're also learning that the process of increasing the erythropoietin has many other metabolic sequelae that might actually be good for the body, not necessarily because of the increased red cell mass, but probably because of the changes in all these things, including SIRT1, HIF, and so forth, anti-inflammatory effect, and everything, that they might be protective. And that there's what we share with our nephrologists and cardiologists. It's a general protective good thing that they do, as long as they don't give you kidney infections.
That was great. Do you have any idea if there are any potential risk factors? Who is developing, a bit more increase in hemoglobin if you start SGLT-2 at baseline? Or is it unpredictable at the moment who will respond better, let's say?
That is actually a very good question. So what you're saying is there any way to tell who is going to have a significant increase in hemoglobin and who is not? But you have to remember that increase in hemoglobin might be a good marker for the activity of the drug. Maybe you want that. And so at the end of the day, what would be the objective of identifying this? Because I think the increase in hemoglobin might actually be telling you that it is doing what it is. In fact, in the cardiology literature, there is a link between the erythrocytosis and cardioprotective effect. Even though it's not because of the red cell mass, there is definitely a link. So the question you ask is good, but what is the objective of finding that? Can we find them? But it is important to identify those who have an underlying myeloproliferative neoplasm. You don't want to do that because they might get thrombosis. Now, that doesn't mean that you deprive them of such a beautiful drug. No, you just need to put them on the right appropriate medication, phlebotomy, systemic anticoagulation, whatever you need to do, without depriving them of this beautiful drug. It's like men, as they get older, they need testosterone. Just because the testosterone increases hemoglobin doesn't mean that you don't give them the testosterone. You give them aspirin and you continue to give them testosterone. Quality of life matters. So you have to take all those things into consideration.
In the series of the 100 patients, you found 10 events of thrombosis, 7 arterial and 3 venous. So just as a non-hematologist, is that something you would expect in this population, or is it a bit, let's say, an increased frequency you wouldn't expect in this population?
It's a retrospective study, so very difficult to kind of make conclusions. But these were all elderly male patients. The median age was 60 plus. They're males with cardiovascular risk factors. So I don't think anything was unexpected just off the bat, but that's why we wanted to analyze each of these events. And actually, there was no correlation with the increase in hemoglobin or hematocrit as such. And I think that's why we concluded that the course of these patients is typically benign, and we want to discourage the audience from discontinuing therapy just because of their erythrocytosis. Treatment was discontinued in about 3 or 4 patients in our series just because of their erythrocytosis. There can be dose adjustments that can be made. We have shown, and the trials have also shown, that there is a dose-dependent phenomena. So the degree of erythrocytosis is dependent on what dose you use. So instead of prematurely discontinuing therapy and depriving patients of the good drug, that may be more recommended than discontinuation.
If I might add something here, as you probably are all aware by now, I am much older than Dr. Gangat. And I used to be young once, like her. And what I have learned over the years is that it's not over until the fat lady sings, meaning it is too early to say anything right now. This is what we found now. But we could change our mind in a year if there is emerging data. In other words, we're not taking it off the table. We are not discarding the possibility that this quote-unquote physiologic increase in hematocrit might not be detrimental. It might be. The data is one data coming from the Mayo Clinic. And we have to wait for others to look into this and either refute it or confirm it. So we have to keep that in mind. We cannot just dismiss the possibility.
Yeah, you already mentioned that. So I saw in one of your papers, you mentioned it, that you see a more pronounced effect if you use empagliflozin 25 milligrams in comparison to 10 milligram. What about dapagliflozin when you use 5 milligrams or 10 milligrams? Have you seen the same effect, that 10 milligram is increasing hemoglobin, hematocrit more efficiently than 5 milligrams, or is it pretty much the same?
In our series, we didn't see a correlation with the dapagliflozin, but with the canagliflozin, we did see a difference between the 100 milligram and the 300 milligram. But I think partly it has to do with the limited number of patients as well with each dose level. The total series are 100 patients. The majority were empagliflozin, and there's a subset that are DAPA, but just to have the power to be able to detect a difference, I don't think our study had that much of a power.
If you see these patients, so we clearly got the message, you would strongly recommend us not to stop the drug because we have all these benefits, both from the cardiological point of view and from the nephrology. But would there be a limit where you would say, well, if the hemoglobin goes above 18, 19, whatsoever, then you should really stop this? Surely you would advise us to reconsider that there's no underlying neoplasm behind it. But if you don't find anything, would there be a limit for the time being?
Beautiful question. And so, as you know, that we deal not only with clonal erythrocytosis, as in polycythemia vera, where you have to keep the hematocrit below 45% at all times. Very important. But we also deal with secondary polycythemia, congenital, otherwise, so-called JAK2 unmutated. And our experience over the years with this secondary polycythemia is it doesn't really matter how high the hematocrit is. So if you extrapolate from that, then we shouldn't really give a target or a threshold for when you want to interfere. In fact, in the old literature with congenital polycythemia, where there's physiologic erythrocytosis, when they phlebotomized those patients, which they thought was quite high, actually there was a higher risk of vascular events on those patients who were phlebotomized. So I wouldn't, it's a little different because that's physiologic. This is not exactly physiologic. So, now the other tricky thing about here is these drugs inherently have a protective effect. The heart, everywhere, they have a protective effect. So even if there is an issue with the erythrocytosis per se, it might be mitigated by their protective effect. So considering all that, if they didn't have the protective effect, maybe you can think twice about it. But considering that they have, I think I wouldn't change anything. But the question for you is, as a nephrologist or as a cardiologist, is to say, well, do I need that high of a drug? If the 20 milligrams is causing this much, do I really need that? Can I go down to 10? I think it's up to you and whatever the patient needs. So the dose and what you do depends on what you think is the value from the SGLT inhibitor to the patient, not the hematocrit level. Am I making sense?
Definitely, yeah. So I would have two final questions. The first one, as you told us that in a couple of patients, the diagnosis of MPN was first made after a patient received the medication, the SGLT-2 inhibitors. So we are no expert in hematology. So what should we as nephrologists, as cardiologists be aware of when we see such a patient? Should we send everybody to the hematologist, or are there some signs that suggest to us when a patient has a substantial increase in his or her hemoglobin that this might be an underlying myeloproliferative neoplasm?
So firstly, before we recommend starting patients on the SGLT2 inhibitor, it's best to take a very careful look at the blood counts. If the hemoglobin hematocrit is already borderline, or if there is leukocytosis and thrombocytosis and iron deficiency or other features, it's best to rule out MPN a priori before you start them. But for example, if your patient had a normal hemoglobin hematocrit and then you start the treatment and it's been a year or two and they develop erythrocytosis, it can get confusing, whether it's a secondary phenomena or whether it's an underlying MPN. Similarly, we need to follow the counts. If the leukocytosis, if there's thrombocytosis, then definitely we need to check. And I think it's a good practice, at least from the hematologist perspective. It's easy enough to screen for an MPN. It's peripheral blood testing. The JAK2 test can be obtained on just a blood draw. So you don't necessarily have to refer the patient to a hematologist a priori. And once an MPN is ruled out, we all feel comfortable letting the hemoglobin and hematocrit be higher, because as I showed you in the 9 patients where it led to unmasking of the MPN, there were 4 catastrophic thrombotic events. So we want to prevent those by early recognition and managing the patients appropriately. And it was interesting that 4 of our patients discontinued their SGLT-2 inhibitor after the MPN diagnosis, and 2 of those, their hemoglobin hematocrit actually reverted back to the normal range. So that's why it led us to believe that it was unmasking of the MPN rather than these patients just having an MPN from before, because that tells you that every patient with MPN may not necessarily have the hemoglobin and hematocrit levels that exceed the polycythemia vera diagnostic threshold. So our take-home message is really for all the prescribing doctors, including general practitioners, cardiologists, nephrologists, is to have a low threshold for screening for an underlying MPN before placing these patients on this medication, particularly if there is some kind of suspicion based on the history and the lab features.
Thank you. Yeah. And my very last question. Now, patients from the field of cardiology who are put on SGLT-2 inhibitors virtually always have either aspirin or NOAC or any other anticoagulation agent. In nephrology, there are a couple of patients who are not yet on aspirin. Neither are they on a NOAC. So when hemoglobin rises above thresholds, would you recommend us to use aspirin in primary prevention then in these patients, or would you do this again on a rather individualized basis?
I think that's a difficult question too, because it has to be individualized. A majority of these patients, they were older males, and if they're diabetic or have heart disease, there's always an indication for aspirin therapy. So that was the case in our series. But I would recommend individualizing the situation. And a baby aspirin 81 milligrams is not very detrimental in terms of toxicities. It's pretty well tolerated from the GI perspective compared to full dose aspirin. So it would not be an unreasonable thing to at least start them on a low dose aspirin therapy.
Can I ask you as a nephrologist, what do you think of the detrimental effects of aspirin on the kidney? I mean, that is something that people haven't given me straight up answer. I mean, we all know about NSAIDs, NSAIDs, but one baby aspirin a day. How does that contribute to, if for someone, for example, who have chronic kidney disease or does not have chronic kidney disease yet? Can you give me, maybe enlighten me a little bit there?
Well, there are subgroup analyses from the large aspirin trials where they used aspirin in primary prevention. And actually, surely, in order to reduce myocardial infarction and stroke. But there are some, again, secondary endpoints looking upon CKD progression, and there was no effect, neither to the good side nor to the bad side. This may be something else when it comes to warfarin, because here we are somewhat concerned that people who are often above the recommended targets may have some minor bleeding, and this may in the long term then reduce their kidney function. So when it comes to warfarin, we are concerned. When it comes to aspirin, we are not really concerned, but neither do we believe that we do something beneficial to the kidneys. Andreas, would you agree with me?
Yeah, I think so too. I think we have a lot of patients on chronic aspirin use, and you don't see a classical association between, baby aspirin, or we are using 100 milligram here, and chronic kidney function decline. And I think most of the studies looking at, chronic painkiller index, so higher doses of ibuprofen or aspirin, they really found a marginal association with CKD progression. So I think it's one of the things in nephrology where we believe that chronic use of painkillers is really bad, but in a way, I think we're overestimating the risk actually of CKD progression when using these drugs for a continuous period of time, especially also because paracetamol and so on also have some kind of toxicity to the kidneys.
And having said that, surely the general risk of bleeding is higher in advanced CKD, but this rather refers to gastrointestinal bleeding and not really to renal bleeding. So thank you so much, this was really a pleasure for us. And I think it's very important to all colleagues in nephrology and cardiology to be aware of this side effect and to know whom to ask when their patients have this increase in their red blood cells. So thanks again. Thanks for doing all this research. And we are really deeply impressed by the vast number of papers you have published in the last years and the last decades. So thanks for doing all this research. Have a nice afternoon.
Thank you.
Thank you. Thank you for your time.